Good afternoon, everyone. Welcome to Common Clinic Challenges and Concerns, a turnkey pharmacy solutions SpendMend company webinar. One of the items of feedback we've received from our past webinars is that there was this great need for a focus in on the challenges and experiences of clinics, where we get so much information around hospitals all the time. So we hope that that you enjoy this session today. I will note first and foremost that the slides and recording will be available to you within 2 days, I believe, of the webinar concluding. It will be sent to the email that you registered with. With that, I'd like to introduce your presenters today. We have Jasmine Muniz-Carteret. She's joining us from Colorado. Team. She managed the 340 Qualified Health Center in the Northeast, where she was also involved in clinical operations and various committees, including customer service, professional development, P&T, and quality. We also have Sabrina Allen joining us from Idaho today. She brings 21 Qualified Health Center experience prior to coming to the SpendMend Pharmacy team. She most recently served as the Senior Director of Pharmacy Services at a large community health center and teaching health center, where she was responsible for opening 2 in-house pharmacies, implementing clinical pharmacy services, overseeing program growth through contract pharmacy arrangements, and helping start a PGY1 community-based pharmacy residency. So I hope you enjoy the next hour that you get to spend with our all-star grantee auditor team. And with that, we'd love to get an idea of who we have in the room today. So if you wouldn't mind just taking a moment and indicating on the poll on your screen what type of entity you're joining us from today. All right, we've got about 90% of people responded. So we have almost 2/3 of our attendees today are from hospital entities or others. So it could be, consultants or vendors or what have you. But about 1/4 of our attendees are from FQHCs or FQHC lookalikes, which is representative of kind of the greater portion of grantees out there that do fall under those categories, with a smaller portion of Ryan White's and STD clinics and other grantees. So thank you, everyone. Oops, I think I have to share the results. I apologize for not hitting that button, but that is kind of who makes up our group today. So thank you for that. And with that, I will hand the presentation over to Jasmine and Sabrina.
All right, thank you. So I want to start off by saying that Jasmine and I have no conflicts of interest with this presentation. Next slide, please. All right, and we're hoping at the end of this presentation that you'll be able to discuss the different approaches that manufacturers have taken in imposing restrictions on 340B drug pricing through contract pharmacies, particularly as they pertain to clinics and grantees. We also hope that you can explain HRSA's expectations for the provision of data when engaged in a HRSA audit, and create a provider list and administer drug documentation format that will meet HRSA's expectations. And lastly, we're going to review the different mechanisms by which clinics and grantees can manage their clinic-administered drugs as it pertains to the 340B program and Medicaid billing requirements. Next slide.
As part of today's presentation, you also have continuing education credits that you can apply for. So these are our questions for today. Which of the following manufacturers has limited the distribution of 340B drugs to contract pharmacies for consolidated health center programs, CH type entities? Number 2, what are HRSA's requirements for the provider list submitted in response to the data request list? And number 3, a true or false question, a clinic or grantee can maintain an exclusively 340B inventory for clinic administered drugs if they elect to properly carve in Medicaid. So we'll have the answers to these questions for you at the end of our presentation, but hopefully you'll be able to get the answers throughout our presentation as well. Next slide, please.
All right, so let's first take a look at what has been going on in the manufacturer world. Next slide, please. So in the last year and a half, there's been a lot of manufacturer developments, 16 to be exact as of today. I don't know about you, but I open my email and I'm always wondering if I'm going to see number 17, limiting restrictions to contract pharmacies. Well, what do we need to worry about as grantees and clinics? There's really only 6 that you need to worry about of the 16. And you can thank Eli Lilly for starting off the snowball effect of all the manufacturers jumping on board. Next slide, please. All right, before we get started, I wanted to give you a little bit of background on 340B ESP. You'll hear me talk about that a lot in the next couple slides. 340B ESP is the platform that manufacturers use where entities can upload their contract pharmacy claims data to get pricing on particular items that have been limited by manufacturers. For those of you who are not familiar with 340B ESP, you can go to their website and learn more about them if you would like. So these next few slides, and as was mentioned earlier, you will get these slides, so don't frantically try and write down all these restrictions. We put them in alphabetical order, not in order of when they became effective. So we'll start first with AstraZeneca. They were the second manufacturer to limit 340B pricing on our contract pharmacies. So they will not accept orders for and ship 340B drugs to contract pharmacies, regardless of if you upload your claims data into 340B ESP or not. So they are one of the few that do not use the 340B ESP platform. You can designate one contract pharmacy if you do not have an in-house pharmacy to get 340B priced medications at your contract pharmacies. You have to contact them directly. The email is listed there, and they'll send you back a form that you need to complete and send back in. And it does take a little bit if you choose to do this for it to become effective. So do keep that in mind if you decide that you're going to start participating. It's not I fill out the form and it starts the next day. A couple examples of drugs that might sound familiar from AstraZeneca is Atacand, Nexium, and Brilinta. That's just a few. We listed their labeler codes as well if you want to look up all the rest. That is what AstraZeneca is doing. Next, we have Bristol Myers Squibb. They were the 13th manufacturer to limit 340B pricing at contract pharmacies. This one I actually almost missed because they're limiting immunomodulatory drugs for all covered entities or IMIDs. And I almost missed that because at first it sounds like it's just for hospitals on their non-IMIDs, but it actually does include clinic and grantees for their non-IMIDs. I don't think these are medications that clinics and grantees prescribe a ton, if at all, and so that's why it's easy to miss. You can designate one contract pharmacy for these medications. The trick here is it has to be an in-network IMID designated specialty pharmacy location. So they do limit you to that in order to access 340B pricing on those medications. and you submit your claims data directly to Bristol Myers Squibb. Again, they do not use the 340B ESP platform. The next one on the list is Eli Lilly. They kind of started it all. And I think if you weren't paying attention in July of 2020, you may have missed this. They started out really small with Cialis, limiting pricing to contract pharmacies in July of 2020. And then in September of 2020, they pulled in all of their products. So if you kind of missed that first, they were the first one. If you don't have an in-house pharmacy, they did allow you to designate one contract pharmacy. And then they also made an exception for insulin if you passed your savings on to the patients. This came out right about the same time as the executive order did for access to affordable life-saving medication. So in the beginning, Eli Lilly was a little similar to AstraZeneca in, you could have one contract pharmacy if you did not have an in-house. And the insulin savings, you had to give them to all of your 340B eligible patients at cost. The contract pharmacy or the covered entity could not add on a dispensing fee. You couldn't bill an insurer or a payer. And you had to provide, again, the claims level data of these, of your insulin. And then they changed in December of 2021, so last December, they'll allow you to access pricing at unlimited contract pharmacies if you submit your data through 340B ESP. You're still excluded if you have an in-house pharmacy, but they did make it a little simpler to submit your data and expanded that to multiple contract pharmacies. And this kind of started the snowball effect again of it all, as they were the first one to impose 340B pricing restrictions at contract pharmacies. Next slide, please. All right, thank you. And we have our last three. So we have Gilead, which is a little more recent. They were number 15 in the list of manufacturers imposing restrictions. And they said that you can only obtain 340B pricing for contract pharmacies if you submit your data to 340B ESP. And they only put restrictions on a few medications. And those were Epclusa, Harvoni, Sovaldi, and Vosevi. Those might sound familiar to you. Those are all hepatitis C medications. So you're allowed to designate one contract pharmacy without submitting claims level data to 340B ESP if you don't have an in-house pharmacy. So if you have an in-house pharmacy, your 340B pricing at contract pharmacies no longer exists. This one had quite a bit of 340B savings. So was a little bit of a sticker shock, I guess, to some of us out there. It limited our treatment for hepatitis C and obtaining those 340B savings. And then next we have Sanofi, which was the third manufacturer that limited restrictions. So if you're following along, the first three manufacturers, you had Eli Lilly, then AstraZeneca, and then Sanofi. They had restrictions for all covered entities. And with Sanofi, you cannot access 340B pricing for contract pharmacies unless you submit claims level data through 340B ESP. Again, you're allowed to designate one contract pharmacy if you don't want to submit data to 340B ESP, and if you have no in-house pharmacy. One kicker to Sanofi that was a little different was the contract pharmacy must have a HIN number. For those of you that don't know what that is a healthcare industry number. And some folks were having trouble finding that HIN number. And then I just did a quick research, and the HIN number is not free. It does come with an initial fee of around $100 and then renewal each year of $50. So I know some entities were struggling with trying to find that HIN number for their contract pharmacies. And then last, we have United Therapeutics. They were the 6th manufacturer to impose restrictions. And similar to Bristol Myers Squibb, this one didn't, you may have missed this one, is a clinic or grantee, because a lot of the medications under United Therapeutics we don't see. And they had 2 phases. So the first phase, when they came out, said you had to have a purchase in the first 3 quarters of 2020 to be eligible to have 340B pricing at contract pharmacies in November. And then they added a second phase where you had to submit claims level data through 340B on a regular basis. And that was to start in December of 2021. There is no exception if you have an in-house pharmacy prior to December of 2021. They kind of changed that so that if you had an in-house, as long as you provided claims level data on a regular basis, you could have 340B pricing at contract pharmacies. And with that, I think we have another poll question for you.
Before we get to the poll, Chelsea, I just wanted to point out for, and Sabrina and to everyone watching, Sanofi is specifically for consolidated health center type entities. So this does not affect other grantee types. They're really focusing in on hospitals and CH type entities for their restrictions.
Thank you, Jasmine, for that.
That's a great reminder. I think one of the other ones we can enforce Sanofi is particularly
Chelsea, we're having a little trouble hearing you. You're breaking out a little.
I apologize. Can you hear me better now?
Yes.
Yes.
Okay. That was a great reminder. And I just wanted to remind everyone that if you are looking to obtain an HIN number, we do have a past blog that kind of dug deeper into the HIN number issue for covered entities, particularly around working with Sanofi. So we have that as a resource as well. And with that, we're moving on to how entities are managing these challenges with manufacturers, which brings us to, as Sabrina said, our next poll. So we're wondering how your organization has interacted with 340B ESP to date. You could have no interaction with it. You may have enrolled one pharmacy, but are not submitting any data, or you may have begun submitting 340B qualified claims so that you can access some of those restricted drugs. Looks like we've got about 70% of people responding. We'll close that. About 3/4 of attendees that responded have had no interaction with the platform to date. But we do have 15% that have enrolled a pharmacy, submitted claims yet, and just over 10% that have submitted 340B qualified claims. And this is definitely in line with what we're seeing as market trends across all covered entity types, as more and more covered entities are not only just enrolling one pharmacy, but also making the decision around if submitting claims is right for them. And with that, hand it back over to you, ladies.
All right. So what are we to do? So there really is no right or wrong answer. Each covered entity needs to make their own decision. You need to look at your dispenses, do a cost benefit analysis, and kind of see what 340B savings you would be losing if you don't submit. And then again, you need to look at your staff. Do we have the resources to get this data? How much time is this going to require? There's no one size fits all. Each grantee or clinic is unique. So you need to put a team together and kind of look at this. You will probably need to involve legal counsel because you'll need to look at some of your contracts and make sure that you can provide that claim level data to 340B ESP. I wish there was a simple answer that I could give everyone. Unfortunately, there's not. So again, everyone just needs to kind of look at their own program and see what as a grantee or clinic that you want to do. And with that, next slide.
Okay, so we are transitioning topics. I'm sorry, Jasmine, we
It's okay.
did. And before I launch this whole question, I do just want to remind attendees that if you have questions as we go along, there is a Q&A tab in the bar of your GoToWebinar. And if you want to submit questions, sure that those get answered at the end during our Q&A, just so you guys know that that is available. And with that, our last poll question, as we kind of delve into HRSA audits, looking at, with the folks in the room, have you gone through a HRSA audit recently? Do you have one scheduled to be going through soon, just to help frame conversation around recent changes and expectations? All right. So it looks like we have a pretty decent percent, 35% of folks who have not gone through a HRSA audit at all. About 40% that have gone through a HRSA audit, but it's been over a year. 20% with the more recent changes that we'll be speaking about today. And then a small percentage that are preparing for their HRSA audit upcoming. To help frame the conversation as we hand it over to you, Jasmine.
Thank you. And thank you, Sabrina, for that detail about manufacturer developments. It feels like there's always something new every week, and it's hard to keep track of, especially as manufacturers change their policies from their initial letters. Unfortunately, that's not the only thing covered entities have to worry about in terms of keeping up with. HRSA audits are evolving. At the beginning of COVID, HRSA audits transitioned to remote-based audits. And now they are starting to reintroduce remote and on-site audits, as well as expanding on their data requests. They are becoming a lot more detailed in what they're looking for, and it's important to maintain what we like to call a HRSA audit go bag or a ready bag, that your documents are kept up to date throughout the year. A HRSA audit notice might come. It seems like a few weeks is a lot of time to get that data prepped, to get your documents well labeled and organized and ready to go. But that time goes quickly, especially if people have, if you have staff members that are taking time off, if you are approaching the holiday season. HRSA does not stop auditing during the holiday season. I can attest to that. And so it's important to stay ready. So we're going to point out a few of the changes that have come through in recent HRSA data requests. We're not going through every single data request, but hopefully go through the most important ones where we've seen some significant changes and where clinics and grantees often struggle in having this documentation. So the first data request item we're going to review is the 340B universe data. So the request for universe data includes all of your 340B areas. This is going to be your clinic administered drugs at all of your locations, your main associated site, all of your associated sites, as well as your pharmacies. This will include your entity owned pharmacies and contracted pharmacies. HRSA requests a 6-month time frame of data. Preferably in Excel format. That is the best practice. I know oftentimes clinics and grantees can sometimes have manual tracking, paper logs for these administrations, but best practice would be to provide Excel documents. There are some specific elements that are requested in the data. They'd like to see the drug name, the NDC, acquisition price, account type, account number, if you're able to provide that, 340B ID, quantity, a patient identifier, the payer, order date, provider, location, and date administered. So these are the fields that a HRSA auditor will request. It's best practice to provide all of them. Of course, it'll make the audit go a lot smoother. I want to note that it's really important to maintain all of your auditable records. Just because you might have a handful of clinic administered drugs, or you're not purchasing a lot or a high volume or high cost clinic administered drugs, doesn't mean you don't need to provide those records. It is imperative to maintain auditable records for 340B eligibility. So being able to produce these records is going to help you in having a smooth HRSA audit. Even if you provide 95% of all of the auditable records, if there is a portion of those records missing, it puts you at risk of a finding for not maintaining those records. So next slide. Okay, the next data request item we're going to review is the provider list. So the provider list now with HRSA, they are asking for all of the covered entities eligible providers, including the first name, last name, NPI, and whether or not that employee is employed by you or contracted, and then including a start and termination date for that employment. You should be ready to provide proof of employment, contracting, or credentialing for these providers during an on-site or remote audit visit. This is something that HRSA auditors have started to include in their auditing. They won't give you typically advance notice of these providers, but just be ready. This is part of your HRSA team readiness and working with your credentialing department or your contracting department to access those documents. I wanted to point out that you shouldn't rely on your TPA's provider list. I know that they do maintain provider lists for you, and you work in conjunction with your TPAs to update those provider lists, but they might not have all of the data elements that a HRSA auditor is requesting, and they might also not be maintaining any of those terminated providers. So it's best practice as a covered entity to have your own internal provider list that has all of these data elements, as well as having what we call a master or perpetual provider list, where you're including providers that were terminated maybe a year ago, but you might run across some of their prescriptions in your sample audit period. So making sure that you have these auditors or these providers, maintained on your provider list is going to be very important. Okay, next slide. All right, the next HRSA data element is purchasing documentation. So this is where HRSA has started to become a little bit more involved in their data request. So for purchasing documentation, there are 3 specific data request items. The first is a listing of all of your accounts. So really we think about this as a purchasing crosswalk, and we have an example of what that could look like in our next slide. But basically HRSA is looking for you to list out all of the different accounts that you have for purchasing medications, either at your in-house pharmacy, your contract pharmacy, or your clinics. They do want to have all 340B, GPO, WAC. It doesn't only include 340B accounts for this first data request item under purchasing. What they do specifically ask for 340B accounts is that you include the 340B ID that's associated with that account, or the 340B ID that was used to establish that purchasing account or that 340B account. So really you want to maintain a document that lists all of your accounts with all of the associated vendors. The next item for your purchasing data is to provide a copy of an invoice for each account. This is a massive request if you have a big system or a big clinic system, a big grantee, lots of associated sites, potentially a lot of different vendors. This is something that might take some time to prepare. So making sure that you're providing one invoice, a copy of one invoice for each account that you have listed in data request element 1 of purchasing documentation. So this is again one invoice for each account, including 340B, GPO, or WAC. We want to point out, don't forget about the direct purchasing accounts that you have or the direct vendor accounts that you have. So you might have a primary wholesaler, whether that's Cardinal or AmerisourceBergen, maybe McKesson. That's where you're going to be potentially purchasing the bulk of your medications from. But you don't want to forget vendors like Paragard, especially for family planning grantees or clinics, where you might have also CuraScript or Theracom for Nexplanon procurement. So you want to make sure that you are mapping out and documenting all of the different vendor accounts that you have, not only your primary wholesalers. And then finally, the last data request item for purchasing is to provide all 340B purchase history for the audit timeframe. So again, that's going to be a 6-month timeframe. And they do request that you include the below data fields. So this is a new element in the data request as of fiscal year 22. They are asking specifically for all of these items to be included in the purchasing history data set. So that includes ordering location, wholesaler name, account number, invoice date, drug description, drug NDC, quantity ordered, and the price paid. So this is quite a large data request item and something that you can maintain throughout the year and have it ready for a HRSA audit instead of working to get the copies of all of the invoices, for example, right when you get your HRSA audit data request. Okay, next slide, Chelsea. Here we have an example, a template of what your purchasing crosswalk could look like. Again, it includes the vendor name, the account number, the account name, the account type, whether or not it's a 340B account, a WAC account, or GPO, and then a reminder that for all 340B accounts, you want to list your 340B ID that was used to establish that account. And then we also include a ship to and bill to. This will help you manage whether or not you've submitted invoices. If your invoices, this is a good auditing process to make sure your invoices are matching what you have listed on OPACE, for example. So we really recommend maintaining this purchasing crosswalk throughout the year. Next slide. Okay, on to contract pharmacy documentation. So for contract pharmacy agreements and documentation, HRSA is asking for a few things. They're now asking entities to provide a list of contract pharmacies from the beginning of the audit period through present. So although your data sample set is going to be a 6-month time frame, the documentation for your contract pharmacy agreements and just contract pharmacies in general are going to be longer, typically longer than that 6-month time frame. So it's going to be from the beginning of that 6-month time frame, basically through the day of your audit. So if you have contract pharmacies that were registered pretty recently on OPACE, for example, you'll want to include that in the documentation that you're providing to HRSA. What they are now asking covered entities to include in this list of contract pharmacies is whether or not that pharmacy is being utilized by the covered entity. Basically, if it's an active contract pharmacy, if it's in the process of being implemented, if you have any dispensations, any qualifying dispensations from that location. This just helps a HRSA auditor assess whether or not you've provided all of the 340B universe data for the contract pharmacies as they should expect to see. So it helps auditors cross-reference your contract pharmacy list, whether they're active, and the data that you've submitted. The next item that they're asking for contract pharmacy documentation is all of your original agreements and any amendments or addendums that come with that. So this is an area that I've seen a lot of covered entities struggle with in maintaining this documentation. It can get to be very tedious when you have a lot of contract pharmacies. Maybe you're switching TPAs, so now you've lost the original agreements and you're looking for that original agreement because you only have the most recent one with your newer TPA. It is very important to maintain that original agreement, even if you switch TPAs later on. A HRSA auditor is going to want to verify that your contract pharmacy was fully executed prior to the date of registration on OPACE. If you fail to produce these records, it could result in a finding for having a contract pharmacy registered without a written contract in place, which would then subsequently result in termination of that contract pharmacy. So it's really important to maintain these original documents as well as any updates to that document. HRSA auditors have now started asking for covered entities to provide these documents with a few highlighted areas. This makes it a lot easier for a HRSA auditor to find the documentation or the language that they're looking for to make sure your contracts are effective and accurate. So they're asking for you to highlight signatures, including both dates of both parties executing the contract, the name and address for each contract pharmacy location participating in the contract pharmacy agreement, and each covered entity location by name and address, or if you have an inclusive statement that identifies all of your associated covered entity locations participating in that contract pharmacy agreement. As a side note, we as a team at Spendman Pharmacy generally recommend that you have an inclusive statement, especially if you are a covered entity that adds a lot of new locations pretty frequently or makes changes to your covered entity locations. It's just a little bit less to manage in terms of having to issue amendments with new covered entity lists. So having that inclusive statement is going to help in reducing that workload. So making sure that you have the ability to highlight these areas in your contract pharmacy agreements and then upload them appropriately for HRSA. So being ready to scan all of your contract pharmacy agreements. Again, this is not the most fun part of being HRSA audit ready. We understand that, but making sure that these are scanned in chronological order and that you have pages that aren't upside down accidentally in your scanned files. So maintaining these and having them well labeled is going to make your audit go a lot smoother for your HRSA audit. Okay, next slide. Here we have an example of what your contract pharmacy listing can look like. Having your pharmacy name, the address of your pharmacy, whether or not that location is considered an active contract pharmacy. And by active, we mean there are qualifying claims versus not active or active with an asterisk. You had no qualifying claims during that audit period, so the HRSA auditor should not expect to see any claims data during that time frame. And we also recommend including the TPA in there. It just helps you map out all of your contract pharmacy operations and makes auditing a little bit easier. Okay, next slide.
All right, thank you, Jasmine. I will jump in here now and talk about clinic inventory management. What are our options? Next slide, please. So which is better? Should we use 340B inventory for all our clinic administered medications? Should we have a limited supply of 340B medications in our clinics or no 340B medications in our clinics? Next slide. So our first option, all 340B inventory in our clinics. Well, first, can you produce auditable records? Just as a reminder, covered entities are expected to maintain auditable records, which include patient-specific administered drug utilization records that can be used to audit for patient eligibility, and drug-specific administered drug records, which can be used to demonstrate that what was purchased is generally consistent with what was documented as administered to 340B eligible patients or otherwise used. So can you show that what you purchased for use in your clinics was administered to eligible patients of your clinics so that you're not over purchasing and have a risk of diversion? So first you kind of have to take a look at where all your 340B drugs are stocked and they're administered. You know, do we have the room for them? And how are they going to be documented? So can our electronic health record document the administration of the medication? And then can we get reports that show what was administered? I know sometimes EHRs can document, but getting the reports, if you don't document in the right spots in the record, you might not get the reports you need. And then if you get reports off of billing, you might miss some things like Jasmine was referring back to under HRSA data requests, that you might only get 95% of what was administered because you may not be billing for all your medications. Or, do we need to have paper tracking logs? If, will that work instead of, documenting it in our EHR? It kind of just depends. You kind of have to look at what is reasonable for your organization. And there is some barcode scanning software out there that does integrate with your EHR. Typically those cost money. So it just kind of depends on what you're looking for and what tracking method will work for you if you're going to have 340B medications in your clinic. And then the second thing you need to worry about is Medicaid billing. On the OPACE database, they do ask that question. Do you bill 340B purchased medications to Medicaid? And with the database, they are particularly talking about a Medicaid fee-for-service. So if you are going to bill, you do need to 340B purchased medications, you do need to make sure you have your selection correct in OPACE. And then you also have to look at your state requirements because not all states use that Medicaid exclusion file from OPACE to document who's billing Medicaid fee-for-service. So your questions are you going to carve in? Meaning, are you going to bill Medicaid fee-for-service for 340B purchased medications? So what is your state requirement? Is it appropriately checked on the OPACE database? You have to take a look at all that. Or you can purchase all your inventory at 340B and carve out and not bill Medicaid fee-for-service for any 340B purchased medication. Again, this is each individual clinic or grantee has to make the decision. Next slide, please. And if you choose not to do all 340B medications, maybe you might want to have a limited 340B inventory. It might be a little easier to maintain, might be a little easier to produce auditable records. It just kind of depends. That is something you're going to have to take a look at as an entity to decide what you want to do. And then you again have to take into consideration Medicaid billing. There is a few challenges posed if you bill Medicaid fee-for-service for both 340B and non-340B drugs. There is some states that rely on that Medicaid exclusion file. And if your MPI number is listed on that Medicaid exclusion file, you are now excluding your state from getting some rebates on some non-340B purchased medications. So that is something that you'll need to take into consideration and look at your state billing practices. And then you can carve out, which means that you're not going to bill Medicaid fee-for-service for any 340B purchased drugs. Again, that goes back to the previous slide. As a grantee or clinic, you're going to have to decide which way you would go. And then lastly, we didn't put a slide on this, but you can choose not to have any 340B medications in your clinic. Again, it does take resources and time, and you kind of have to look at your cost benefit. Does it benefit us to have 340B purchased medications in the clinic, or do we just not have the manpower and the resources to have 340B medications in our clinic? Again, no right or wrong answer. The biggest thing is whatever you decide to do, if there is 340B purchased medications, you'll need to make sure you have auditable records. All right, next slide.
Okay, and before I jump into these answers, I did want to point out, to Sabrina's point, a lot of the reason that it's a benefit to have a Medicaid carve-in, for example, is that it's a little bit easier to manage a 340B and all 340B inventory. If you are carved out and trying to purchase 340B, it's sometimes difficult to manage. Well, how are we sure that we didn't give a 340B drug to a Medicaid patient? So there are quite a few considerations when implementing your clinic administered drugs, and sometimes whether or not you're getting reimbursed, if you're able to establish different price tiers for different payers. For example, if you're carving in Medicaid and you have to bill at acquisition cost, but you also want to bill private payers at your usual and customary or your contracted rates, that can sometimes be a challenge. So taking all of that into consideration is going to help you make the best decision for your covered entity for clinic administered drugs. So now for continuing education questions for your CE credits. Question number 1, which of the following manufacturers has limited the distribution of 340B drugs to contract pharmacies for Consolidated Health Center programs, CH program types? So that is Sanofi. So Sanofi did restrict pricing for hospitals, but they also added CH entity types in there. They left out the other grantee types. So answer number 1 would be Sanofi. For number 2, what are HRSA's requirements for the provider list submitted in response to the data request list? That answer is D, an Excel spreadsheet of the covered entities eligible providers, including first and last name, NPI, employed or contracted status, start date, and termination date. And then number 3, true or false, a clinic or grantee can maintain an exclusively 340B inventory for clinic administered drugs if they elect to properly carve in Medicaid. That is true. If you are carving in Medicaid and meeting HRSA's billing requirements as well as your state's billing requirements, you can maintain a 340B only inventory at your clinics. A little asterisk there, I want to really emphasize the auditable records. Please make sure that you're able to produce auditable records for everything that you're purchasing on 340B. Okay, next slide. All right, that is all that we have today in terms of the presentation, but Chelsea, I'll give it away to you.
Thank you so much. That was wonderful, Sabrina and Jasmine. Hoping now to kind of tap into your experience in all of the different clinics and grantees for audits. So that have come in so far, and please, audience, continue to ask any questions. Feel free to continue to submit them the side panel that you have there, and if we don't get to LinkedIn afterwards. So first question we have is regarding the ordering location for the HRSA audit request, or sorry, HRSA data list. If a parent location orders medications for all child sites or all associated sites, do they still need to indicate which child site is?
Chelsea, you might have to repeat the question. You're breaking out. We last heard if the child site is, or if the parent site is ordering for the child site. I'm so
sorry.
That's okay.
For the HRSA data request list, indicating kind of the map of your universe and how drugs are purchased, if a parent locates all associated sites, can you still not hear me because you're smirking?
Okay. Yeah, we're good.
Okay. If a parent location orders for all sites, do they indicate which child site or associated site going to the parent location? How do they navigate if different locations are ordering and perhaps getting shipped to different locations?
Okay, so I think the question is whether or not you have some sort of centralized purchasing process and you might be purchasing under one account, or you might be having drugs shipped to one location and maybe subsequently distributed out. So there's a couple different scenarios here based on the question, I think. So I would start off by saying if you're purchasing under one account, one 340B ID, one account number for multiple locations, that's perfectly fine. I think it would be helpful for a HRSA auditor to know whether or not drugs are being administered at a specific location and where they're being shipped. So if your vendor invoice is saying that your drugs are all being shipped to your main location, for example, and that's what is associated with the bill to ship to on that invoice, And that is also what you have listed on OPACE. I think that's what you would include in your purchasing crosswalk. You would list that account number. You would say that drugs are shipped according to the invoice, shipped to this main location, but your process to that is to then distribute that as needed to the clinic. So really that ship to address is for manufacturers to be able to verify if your location is eligible. And then making note of whether or not drugs are being then subsequently distributed out is going to be helpful for a HRSA auditor. Sabrina, I don't know if you have anything else to add on that one.
I was just reading the question, reading the question again to make sure. No, I don't think I have anything to add to that answer. I think that at least the way I heard the question satisfies the thing.
Yeah, I think ultimately it comes down to transparency and making sure you are communicating your processes to a HRSA auditor as best as possible so that they can understand what should they be looking for on your vendor invoices and on OPACE as your shipping addresses, what kind of inventory should they be expecting at each of your clinics. So having that centralized purchasing and maybe purchasing under one account and then distributing out, you would just want to communicate that to a HRSA auditor.
All right, our next question is to see for a resident physician that works or worked at your location, where the contract would likely be with the School of Medicine and not necessarily with the resident themselves.
All right, I will try and tackle that, and Jasmine add on. So whatever your credentialing department has, it shows that provider is privileged to work at your location is what you would need to show. I've seen letter approvals. I've seen the first couple of pages of the contract. I don't know if the School of Medicine would be able to send that, first couple of pages over. Jasmine has worked with a little more HRSA audits than I have, so maybe she can chime in and give what else a HRSA auditor might take as acceptable documentation that resident works there.
Yeah, I would agree with that. Anything that shows that the doctor or the provider has privileges at your location, whether that's through the School of Medicine, you would want to get the contract with the School of Medicine, most likely if you can. Chelsea, I don't know if you have anything else to add on top of that, because this seems to be a pretty new request from a HRSA auditor within the last year or so. So there are several types of documents that the HRSA auditor is willing to accept on this.
I agree. I've seen kind of the same as what you both have described, different types of documents being accepted based on what's available for each kind of covered entity. Most part with residents, it is usually that resident contract that states where they are going to be practicing. And it might be at multiple locations, which is okay, but a lot of times I've seen that used for residents. We are going to keep rolling with some HRSA data request questions. I will answer one quickly that says, does SpendMend obtain the HRSA data request specifications from office or through HRSA's website directly? And the answer is neither. We support many of our clients through HRSA audits, and so from the clients that are getting HRSA audit notices. So they're coming right from the HRSA week. Let's see. Next we have, do we need to provide one invoice for each account, even if we have not purchased in the 6-month time frame from the HRSA data request?
Yeah, that's a good question. I actually have never run into that scenario in a HRSA audit that I've completed. I think a HRSA auditor would like to see one anyway, because they do want to verify that ship to bill to address that you have listed on OPACE. That's my take, but Sabrina or Chelsea, if you've seen anything else.
I don't have anything else to add, so I will see if Chelsea has anything else to add.
The other approach that I've seen taken for HRSA audits is actually getting an email confirmation from that distributor or wholesaler confirming that no 340B purchases were made on that account in in this date time frame, and then kind of printing that to PDF and providing that for the HRSA audit as well. So that seems to have been accepted too.
Yeah, and I'd like to note that a HRSA auditor is going to be in constant communication with you. So if there's something that you submit that doesn't meet their standards, they're going to give you advance notice and give you the opportunity to submit other data. You have up until midnight, the last day that your HRSA audit is scheduled, to be able to continue uploading data to meet their requirements. So although there's a lot of stress around HRSA audits, there is a little bit of flexibility in being able to communicate with your HRSA auditor and any of your consultants, if you have one, to be able to meet those requirements. And I'd also like to add that as much as we would love consistency during HRSA audits, there is variation. Every HRSA auditor seems to have a little bit of a different process in what they want, and they'll be sure to communicate that with you.
Lovely. All right. We also have, again, around the invoices, do you provide those 40B accounts, or do you provide those for all of your accounts?
Can you repeat the question? Sorry, I didn't quite hear it.
Of course. Yeah, around the purchasing invoices, do you have to show 40B accounts in addition to your 340B accounts?
Okay, so the way that the data request is written in the HRSA official data request, they do ask for a copy of the invoice for each account that is listed in data request A for purchasing documentation. So the way it is written, they are asking for an invoice for each account that you've submitted on that data list. In practice, if they change that, that's up to the HRSA auditor. And Chelsea, I don't know if you've seen anything differently there.
No, I've seen that as well. So the purchase history report that they request is only for 340B purchased drugs,
Yes.
but the invoices are for every account in your full account listing. All right. Lilly products. If an entity-owned pharmacy dispensing insulin for a Lilly product, did they only charge at acquisition cost? And is that for all insulin or just certain kinds of insulins? Can we kind of backtrack to the restrictions that Lilly's put into place and kind of the nuance around the insulin piece of it?
Sure. Sabrina, do you want to take this one, or would you like me?
I will let you take it.
Okay. So as far as we understand it, the Eli Lilly restrictions are for contract pharmacies only. So we have not seen this impact entity-owned pharmacies with the updates that they've made. This might be a little bit confusing because during the Trump administration, there was some language being circulated that insulins would have to be provided at cost to 340B, at 340B covered entities to all patients. This was not made effective, so that was discontinued for clinics and grantee types. So Eli Lilly has a restriction for their contract pharmacies. That was a nuance that they had, that you could continue to access insulins free of restrictions as long as you were providing that at cost to the patient. That's the way that we understand it. Chelsea or Sabrina, I don't know if you had any other input on that.
Nope, that is the way that I understand it as well.
All right, we've got time for one more question, and we're going to switch over to our clinic administered drugs now. What insight can you provide on the best way to track clinic administered drug inventory in terms of ins and outs, what you're ordering, what's getting used, what might be expired? Do you use a spreadsheet? Do you use invoice records, the medical record itself? What's the best way to do that, or is there not a best way?
I can take this one. I wish there was a best way. What you need to look at is what is going to work best for your organization. I mean, it's going to vary. I have seen it tracked fully in the electronic health record. I have seen some places just track on paper. I've seen a combination of those. I've seen some barcode scanning. the one thing you want to make sure is that you can prove with auditable records is that what you purchase, so for instance, if you purchase 10 Depo-Provera and in the month you use 3 Depo-Proveras, that you have 7 left. And if you go to your cupboard or wherever you're storing your medications, that there is 7 left, and if not, where are the ones that are missing? You know, did one expire, and how are we tracking our expired medications? Did we return one? Did we start to use one and then waste it? Those are all things that you have to take into account. But there really is no there's really not one best way. It's kind of whatever works best for your organization. And Jasmine or Chelsea, I don't know if you have anything to add.
Yeah, I think overall the goal is to make sure that you're following the equation of purchases minus utilizations equals inventory on hand. And that utilizations bucket includes anything that's administered, expired, wasted, returned. So whether or not you are tracking expired and wasted meds manually on a paper log, or if your medical record is able to support that, if you have an inventory module, potentially you're using a reverse distributor, and your reverse distributor might be able to provide you with those records as well. For your purchases, making sure that you're reviewing that on a regular basis, we generally recommend that you're picking a few NDCs every month, every quarter, what works for you, looking at a couple of different locations and rotating around and making sure that you're doing these inventory reconciliation checks. And that'll give you a high level view of whether or not there are glaring discrepancies in your data. For example, if providers aren't documenting the administration of a specific drug in the right spot, or maybe you haven't updated your drug catalog in your medical record where providers could select this drug is being administered. So it really gives you that checkpoint of making sure, do we have big discrepancies in our data? If they're not that big, maybe you might be a few off. It's never great to have a few off, but we know perfection is it's impossible. But as long as you're able to show some records or most records for all of the drugs that you're purchasing, the best would be to have documentation of those expired medications and wasted medications in whatever format works best for your clinic.
Thank you so much, ladies. This has been such a helpful hour. We are at the top of the hour, so we will, as I said, make sure that all the questions that were asked today get answered on LinkedIn. And if you have other questions to follow up with, please feel free to reach out, and we'll make sure to include those as well. Just as a reminder, the slides and the recording and the CE this session within the next 2 days, so you can keep an eye out for that. Thank you again, and have a wonderful rest of your day.
Thank you, everyone.